Good morning, all of you. First of all, let me thank Professor Lahane sir and Professor Ragini madam to give me this opportunity to speak in their instruction course. Both of them are excellent phaco surgeons, but they still believe in SICS also. I am going to speak on the anterior chamber maintainer, a tribute to Professor Blumenthal. He has not invented the anterior chamber maintainer, but he has extremely popularized it through his Blumenthal's closed chamber technique. The anterior chamber maintainer is a small cannula which is introduced at the lower end of the cornea to maintain a sustained pressure, fluid pressure in the anterior chamber. This is connected to the BSS bottle at the height of about say 50 to 60 centimeters. So the chamber is always pressurized and you can work in a normal anatomical surroundings without using viscoelastics. Apart from hydro-expression of the nucleus in Blumenthal's mini-nucleus techniques, there are many various advantages of anterior chamber maintainer. It always maintains a positive pressure in the anterior chamber, so it provides enormous space to work in the anterior chamber. You can operate with all the normal internal architectures and any predetermined maneuver can be executed as planned. The dissection of the scleral tunnel is very easy because the chamber is pressurized, the globe itself is pressurized, and you can very well imagine dissection in a taut scleral wall. There is always one-way flow of the fluid, so organisms are always prevented from entering into the anterior chamber, so there is less chances of infection. It also acts as a tamponade against bleeding. There is less post-operative inflammation because there is always inside-out flow of the fluid. It washes out debris, blood, pigment, cortex, etc. There is a low turbulence and low fluctuation of anterior chamber depth due to instantaneous fluid replacement, and this results in less discharge of prostaglandins as well as leukotrienes. You can always do away with viscoelastics, though it is not a must. Endotoxin loads are vary amongst various viscoelastics as referred by this study. So you can do away with viscoelastics and the chances of TAS are very low. Here are few videos which demonstrate how the anterior chamber maintainer prevents the entry of blood into the anterior chamber. In all these videos, there is bleeding into the scleral tunnel wall, but because of the anterior chamber maintainer, there is always gush of fluid from inside out, and the blood is prevented from entering into the anterior chamber. In the video on the right top corner, I am delivering the nucleus. There is bleeding in the tunnel chamber, but it is prevented from entering into the anterior chamber. My methods are little different because my incisions are depend upon pre-existing astigmatism. As Lahane sir has told, I always do topography beforehand and decide the site of incision as well as the design of the incisions. Now, because of the pressure in the anterior chamber, there is always less chance of expulsive hemorrhage. It keeps the pupil also dilated. The capsular bag also is distended, so the irrigation and aspiration is very safe. And the chances of capsular rupture are less because always the capsular fornice also is maintained. You can very well suck the cortex from the fornices. You can have drug delivery through the IV fluid. ACM also acts as a surge suppressor in cases of phacoemulsification. So it may be perhaps more helpful in MICS, and you can continue installation of topical anesthetics during surgery. Because during the surgery, the incision is open, but because of the anterior chamber maintainer, even if you instill the topical anesthetic drop, it doesn't enter the anterior chamber, it remains on the surface. And in the event of PC rupture, positive pressure always pushes back the vitreous face and the further hazards can be minimized. As Dr. Parikshit has mentioned, ACM also helps in capsular excis. Without viscoelastic, you can do capsular excis because there is continuous fluid pressure and you are working in a deep chamber. So there is no need of repeatedly instilling viscoelastics, and only with the bent needle you can do the capsular excis by passing the needle through the side port. Generally in this technique, my side port is not complete when the capsular excis is done. Only after the capsular excis, I again insert the MER needle on the side port and make it a regular side port, so that the capsular excis also is a totally closed chamber technique. Now here are few videos Now in this case, there was a PC rupture which was found after the lens implantation in the bag. Somehow I was scared of keeping the lens inside the bag. So with the ACM on only, I slowly removed the haptics, took it out of the bag and placed them into the ciliary sulcus. So because of the entry chamber, in spite of the rupture, the vitreous was not disturbed. Now here is a case where again there is a PC tear you can find, but the vitreous face is not disturbed and I could continue with my cortical aspiration and all the steps of the surgery. These steps can be very hazardous and you can be very careful during these maneuvering. Otherwise, it is best to use viscoelastics, at least in such cases, unless you are very expert in SICS. Now here the cortical matter is aspirated, the vitreous is not disturbed and gently the lens is placed into the ciliary sulcus. This was a case of PC tear without vitreous disturbance. Now there is another case where there was a PC tear and vitreous disturbance. I did a closed chamber automated vitrectomy. The vitreous from the antechamber was removed. A little core vitrectomy is done. And then gently I could proceed with my regular cortical aspiration. And the antechamber maintainer was kept on throughout the procedure because that is continuously suppressing the posterior capsule and the vitreous back.
Difficult situation.
And after the gentle cortical aspiration, the intraocular lens was placed into the ciliary sulcus. Only if we put a large instrument into the main channel, there is sudden gush of the fluid outside and the vitreous can get more disturbed. So all these maneuvering should be very gentle. The antechamber maintainer is introduced generally at the lower limbus through a tangential tunnel. This is not a radial tunnel like a side port. You have a small tangential, about 2 mm tangential tunnel with a MER blade and the antechamber maintainer is on and gently introduced and kept on throughout the procedure. There are various types of antechamber maintainers. I will not go into the details, but the commonest use is the one which has screw type serrations, which is called as a Leviquin, and the other one which is popularized by Blumenthal is a flat one, which is a Blumenthal anterior maintainer chamber. Thus, from maintaining the anterior chamber throughout the procedure, it can also have assured cardiac monitor for the surgeons. So with the judicious use of ACM, surgeon can have peace of mind and can take off and land very smoothly. Thank you.